Fine, good afternoon all. It's a slight step change in the type of talk, so a little bit less motivational, so you can do it right at the start, right? Just to balance it out a little bit. So I've been asked to talk about Alpelisib, which, for those that have come across it, you'll know when you have come across it, and for those that haven't come across it, you will come across it. And it's important that we kind of just start to discuss it. So we're going to talk what it is, current guidance in the UK, some data and cases, some management options, and a little summary at the end. Background about oncology and diabetes to start with. So about 20% of people with cancer have pre-existing diabetes. There's increased risk of hospitalization, morbidity, toxicity. The cancer treatment's less efficacious, and you end up having to often either reduce doses, shorten durations, and it impacts both progression-free survival and morbidity and mortality in general. High sugars are linked with overall worse outcomes, generally in patients, but also in particular with cancers, and the risk of recurrence also goes up. And I think that we're happy enough that both historic and novel therapies cause hyperglycaemia. So what have we got? We've got this lovely document that hopefully some of you have seen. The Joint British Diabetes Societies and UK Chemotherapy Board got together and created this document all about oncology medicines and diabetes together. However, there's a gap in it at the moment, and I think it's not necessarily solve the problem I'm going to talk to you about. In fact, it's only mentioned once in the document, because I don't think we knew necessarily a lot about it while this document was being written. So what is Alpelisib, first of all? So it's a medicine that's used to treat breast cancer. It's a phosphatidylinositol 3 kinase inhibitor, which is basically an enzyme inhibitor that works in a pathway within the cells that, the easiest way to think about it is it helps disrupt the energy pathways within the cells, and that energy pathway is linked to glucose metabolism. So it's used in this hormone receptor positive, HER2 negative, and importantly, this PIK3 mutated type of cancer. It can be used in locally advanced or metastatic disease, and the aim of it is really to delay progression and extend survival. It is not to cure, and that's important, and we need to keep that in mind when we talk through this. We use it on top of an aromatase inhibitor plus previous one of these 3 medicines. Jerry's actually very helpfully volunteered to talk us through this slide. Thank you ever so much. So this is the PIK3 pathway. I think, again, what I wanted to just drive home with this is, especially for those at the back who may not be able to see it entirely, is that this is the insulin receptor over here. And throughout this pathway, PIK is basically central in both proliferation, survival of cells, glucose metabolism, angiogenesis, and it's often deregulated in a lot of cancers. So they have this easy access to energy to be able to replicate, move, and survive. And what we know is that for patients that do have this particular mutation, this PIK3 mutation, then they have a 44% increased risk of death than patients without the mutation. So it's not good. So what about the context and the current guidance in the UK? So you'll notice that across here, this is taken from the JBDS document, there's a number of medicines that we use in oncology that can cause different forms of diabetes. So these are some of the targeted therapies. You'll recognize some of the more common ones, maybe octreotide and lanreotide at the bottom. Some of the others, maybe everolimus, possibly. But you'll notice Alpelisib is just here. And at the time, this risk of diabetes, about 37% was estimated when this document was written. The other sorts of systemic anti-cancer therapies are here that create type 2 diabetes. You've got the checkpoint inhibitors, which can induce the immune system and create type 1 diabetes that you may have come across at some point in the last couple of years. So ipilimumab, nivolumab, pembrolizumab. And then we've got some of the hormone treatments down the bottom as well. So essentially, oncology is becoming heavily linked with diabetes. If you haven't already thought about getting some sort of joint posts, then it's a sensible area going forward, just like the surgical pathways Jerry was talking about. Now, I've put this on there, and it's worth mentioning for everyone with the phones, the slides will be available afterwards. You'll be able to delve into them, draw over them if you want to. So they will be available afterwards because I'm aware that this particular slide and some of them look particularly small. But Generally, this is the recommendations for commencing therapy, any sort of anti-cancer therapy in patients with diabetes or without diabetes. So this is without previous diabetes, and it talks about corticosteroids and systemic treatments. It talks about the immune checkpoint inhibitors. It talks about the risk of hypos. It talks about nausea and vomiting and antiemetics. And it talks about managing the person, so how to get them to monitor, how often to do it, how often you do H1Cs, whether you do it at baseline. None of this, unfortunately, covers Alpelisib, which is a complete separate entity related to this pathway. So unfortunately, it's not applicable. NICE, about a year ago, has made this available. And there's a NICE technology appraisal, which means that it needs to legally be made available in centres. So we've got the recommendations here. This is similar to what I talked about at the start. So there's a very particular group of patients this needs to be used in, but it's always in advanced disease to prolong survival. And we're talking months, 5-6 months maximum. I first heard about it when I got a referral from one of our oncologists to say, the summary product characteristics of this medicine says refer to a diabetes specialist. Okay, I've never heard of this medicine. Why have I not heard about it? How has it got to this stage? It was starting to use a medicine that causes hyperglycemia in what you're going to see is an enormous number of people. And I went straight to the resource impact statement, which I can't take a screenshot of now, because at the time, it just said there is no estimated impact to the NHS. As in, they don't think there'll be any impact because it's current pathways. So I said, well, you do realize that the comms related to these impact statements are often taken, and no diabetes team has actually heard of this, despite you saying to refer to diabetes services for pretty much any patient on it. So you'll be happy to know they've now put this little bit of resource impact into it at the bottom here. It's just this bit here. My lasers have run out, unfortunately. And they've also put this other section, which is, however, we've also noticed the summary product characteristics mentions all this about hyperglycemia and all these extra monitoring, all these referrals to diabetes services. So I think it's worth taking the time to recognize that a number of patients are going to require monitoring with regards to this medication. So we'll show you the data. Does it work? Yeah, it works. Left-hand side of the screen, blue line is treatment, red line is placebo. So you'll notice that the blue line is higher, which means more people survive over that time frame. But it is, as you can see by the little box there, months. 5 months on average, extra length of life without progression of their cancer. You'll notice in the non-mutant cohort, which is just to mention it's a very particular group of patients, there's no difference. So it only works for patients who've got this particular mutation. However, and I want to just put this right at the start before I discuss any other data, patients with diabetes were excluded from the studies. So anyone with type 1 diabetes wasn't included, they were excluded. Anyone with type 2 diabetes had to have an H1C of 48 or less. And anyone pre-diabetes was included. So you've got these basically non-diabetes, pre-diabetes, or excellently controlled type 2 diabetes patients. So it's, I would say, when we look at all this data, take this in mind, because this is a very well-controlled patient group beforehand. And here's the percentage that we saw in the clinical trials. So at the top is hyperglycemia. So you'll notice, and I'll show you what the grades mean in just a second, but more than grade 3 is essentially patients with blood sugars of 14 to 27. So we've got 40% of patients overall in SOLAR 1 having hyperglycemia from 14 to 27, 60-odd% actually getting hyperglycemia. This is patients largely without diabetes, remember, or pre-diabetes. And then that was replicated in a number of other trials in similar groups. So I think what's the takeaway is that hyperglycemia is definitely a common side effect. In terms of the grades, they've got American figures because they're a good couple of years ahead of us, but on the right-hand side, you'll also, if you squint from the back, be able to see the glucose levels. So 8.9 and up to 8.9 is grade 1. Grade 2 is 8.9 to 14. Grade 3 is 14 to 27.8. And grade 4 is off the charts. And the SBC actually gives reasonable suggestions to start with as to what to do, which is to intensify treatment or refer to a specialist and do some monitoring. And you'll notice at the bottom it starts to talk about the sorts of medicines that might help, but doesn't necessarily give you any evidence because there isn't any, because there were so few patients, unfortunately, that got treated during the trials. Now, when we look at the onset of hyperglycemia for this group of patients, it really shows up, and it's that this dark blue line here, this top one, it really starts to show within the first 50 to 60 days. So if it's not happened by that point, it's unlikely to happen. It really plateaus out after that point. So if you're going to see it, you see it early, and you can see that really rapid rise. It'll often show up at the onset. Over here, you'll see the mean onset time is just over 2 weeks. And when you start to intervene and give it interventions with medications, it often takes about 6 days on average to bring that down to the lower grade of hyperglycemia. So you can improve things, but gradually. From this, what I want you to take away is that depending on whether you had, on the left circle is normal, the middle circle is pre-diabetes, the right circle is those with diabetes but HbA1c of 48. So you'll notice straight away the dark blue is bad. Yeah, so the navy darkest blue is grade 4 hyperglycemia. So for those that are diabetic at baseline, HbA1c of 48, you can see that a quarter had grade 4, above glucose of 27.7 hyperglycemia. And then over 50% had grade 3, that's blood sugars of 14 to 27. For those with pre-diabetes, again, you'll notice that there's a lot more blue than there is grey. And still, even normal at baseline, about 50% of people will have this hyperglycemia of different grades. There are some risk factors that can help you to identify, and they've done quite well at starting to figure those out. And it's BMI above 30, age above 75, and fasting plasma glucose of 5.6 and above, which is quite a lot of people. So technically, it means that most people will have a risk factor. That means you need to make sure that you're monitored. So we would screen for those. You'll notice the middle bit is consider consultation with a diabetologist, which is why I'm doing this job today, to try and tell people about it, because it's often probably the first time you've heard about it. And over on the right-hand side, recommend lifestyle changes such as dietary advice and physical activity. And I want to remind you, these patients with advanced breast cancer. So we really have to be cautious and cognizant about the advice that we're going to be giving and make sure that it's balanced with the burden of what we're going to ask them to do. This is a slide just to kind of round those up. They did look at lots of other things to try and find a model of what is the most likely to cause, what are the risk factors. So fasting plasma glucose was by far the most prominent variable that helped identify the likelihood of hyperglycemia. But BMI, HbA1c, leukocytes, and age were also up there. What the SBC then also suggests is actually quite helpful now. It does suggest a monitoring pathway for these patients. And actually the oncologist could be, or the oncology nurses, whoever's going to do it, can actually set on this pathway themselves. We don't need to manhandle this. We could teach them how to use the meters. Or most centres, certainly when you're getting your first couple of patients, it might be sensible to, if you have a spare sensor, to just start using those. And I'll show you why, because you don't get experience otherwise. You don't know what you're doing. It's really useful to see the data, and I'll show you some of the helpful cases that have been sent across for this presentation today. But essentially, there's fasting glucose levels at least a couple of times a week as we're going. But as you'll start to figure out very quickly, a lot of patients require intervention. Helpfully, and it's important to bring this back to why we're doing the medicine in the first place and not just talk about glucose. Having worse glucose control, so having diabetes or pre-diabetes at baseline versus normal on the right, didn't change outcomes. And that's important. So if someone's got slightly high glucose levels, didn't change their outcome. So don't overdo it. Right? Think about the same as you do in older persons. The targets need to be sensible for the person that you're treating. We don't need perfect control all the time, given that these people have got maybe 6 to 12, maybe 18 months to live. So I've got case 1 here, very helpfully provided by Amanda. HbA1c was 53 in this, new diagnosis of diabetes at the point of about to start the medicine, no medicine for diabetes. Actually, they read the data and said, we'll start metformin and Lantus 10 days prior to giving the medication in this particular patient. Great. Ended up on 48 units of Lantus, Novorapid, and metformin, and unfortunately, eventually had to stop Alpelisib in line with the SPC because it does recommend stepping the dose down and then stopping if you can't get on top of the glucose levels. And there's a reason for that, and I'll talk through it. But on the Libra data, you can see, can you guess which day the drug was given? So it is high. Yeah, even the people at the back room can see that yellow bit at the bottom. And Case 2 is very helpful by Beth as well. So this patient, this is from day 8 after starting the medication. So don't forget, it's day 15 is the point where you tend to see the most hyperglycemia happening. But this is day 8. Patient at this point was on a Basaglar with a Libre device for monitoring, and this is no diabetes with an H1C of 38 beforehand. Day 8, and you can see over here, very high, 98% of the time was above 14 millimoles per litre. Started on basal bolus, a Basaglar, Nova Rapid. You can see the sort of pattern that looks like over there, still out of range. So we're now at about 50% above target range, 50 within. And this is now on 75 of a Basaglar, 22-ish of a big dose of insulin. You start to see that insulin isn't really working, and that's important to take away. Unfortunately, 17th had to stop the medication because of other side effects, so diarrhea and some other complications. And you'll notice the glucose levels start to normalize quite quickly, you'll be happy to know. 96% of patients in the clinical trials normalize when they come off the medicine, even when they're on the other medicines. So that's good. 2 weeks post-stopping, 86% in target range. And then 1 month after stopping, you'll notice that we're now pretty much 100% in target range. Stopped all cancer medicine for palliation. You'll see that this is the glucose levels a month later, so back to basically normal. So what are the management options? And I want to bring it back to this. The aim of the treatment is to prolong survival, and it may be an increase of months rather than years. So we have to really consider the benefit versus the burden, and don't go in heavy-handed with this. And a reminder of the different sorts of mechanisms we've got to treat what is insulin resistance. Severe insulin resistance, this is the picture of this medicine. So we've got sensitizers, we've got things that secrete insulin, we've got things that, so SGLT2s that excrete glucose, or we could replace with insulin. And we've got lifestyle measures, which might also be helpful. The role of insulin in the PIK pathway. So normally, a reminder to everyone, insulin will switch off gluconeogenesis. It will drive glucose to be converted to glycogen. It will mean that you end up with less glucagon being secreted from the pancreas. And this actually means that there's less glucose available to cells. So within a cell, the high level of insulin increases glucose transport, glycogen synthesis, glycolysis, lipogenesis, and glucose transporters. So insulin is required, as we always tell patients, to unlock the cell to get energy through that pathway. The problem is that tumor cells have exactly the same pathway, and they're a bit more open to the actual, especially when it's a mutated pathway, it's unchecked. They've just got this endless supply of what is anaerobic respiration of glucose. So any level of glycogen that's being produced and stored in the liver that can just throw out glucose when you need it will continue to allow these cells to grow. So when you think about what increase in insulin might do to this pathway, the slight problem is it will inhibit the point of this medicine. We're trying, the PIK inhibitor is there to stop that energy pathway within the cell, and all of a sudden we're giving more insulin, which is going to counteract the point of this medication in both the liver, and you'll notice also within the tumor. So free fatty acids and energy is available again to the tumor cells, and they grow. So actually what we need to be thinking about is, do we use medicines that don't affect the pathway or do affect the pathway? And generally speaking, there is some evidence to show that reduction of insulin enhances the efficacy of the PIK3 inhibitors because of what I've just shown you. So we really need to be using these medicines on the left-hand side as much as possible. So metformin, SGLT2s, pioglitazone, and acarbose. But I'm once again saying you need to balance that with the risk to the person and the fact that you're going to give them a lot of medication burden in their last 5 to 6 months of life. On the other side, some of these may be necessary, but anything that increases insulin might be counterproductive, especially given decent doses of insulin. So when you start to look at the actual clinical trial, SOLAR-1, what did patients require? So majority of patients, over 87%, had metformin in a format. But on the right-hand side, you can start to see how many patients had just metformin, and it's very few. So, in fact, you start to see all of this. So, another 41% required an additional medicine, 30% required 2 extra medicines, 16% required 3 extra medicines, and another 12% required 4 medicines. So this is metformin plus 4 other agents. It's quite a lot, isn't it? There was only 6 patients in the trial that had used SGLT2 inhibitors. So again, it's a really evidence-free zone. We've got the survival time of those patients here in the particular trial. So you can see that they lived a particular number of months, but there's nothing you can draw from 6 patients, really. You can't. Other than to say that, generally speaking, they were well tolerated, as long as they had sick day rules and they were well monitored. Now, for those that get the slides afterwards, have a look at this. It's about mice, and I know that you won't see it at the back, so I apologize in advance, but the take-home message from this slide will end up being that given an SGLT2 plus metformin in mice models of this particular cancer, really benefited in the glucose levels. So this grey over here is alpelisib, dapagliflozin, and metformin together, and that is better than dapagliflozin on its own or metformin on its own. On the right-hand side, this is, again, survival tumor volume in the rats, in mice this is. So on the bottom half, you'll see that there is the combination of alpelisib on its own, alpelisib plus metformin, or alpelisib plus SGLT2 plus metformin. And the one that's the best in terms of tumor volume is giving metformin plus SGLT2 and the alpelisib. Giving metformin on its own is bad. All right, so make sure you're giving the alpelisib tumor volume. Now, there is an ongoing clinical trial that has been started looking at prophylactically giving metformin and SGLT2s in this group of patients. And that's something to think about. But it's only just started, the results are awaited. There is, however, quite a nice study called the Metallica study, which has already done this for metformin. So it's looked at patients and it said anyone that had, so cohort A were patients without pre-existing diabetes, and cohort B were those with pre-diabetes. And they were either, essentially they were given metformin titrated up to maximum tolerated dose, so a gram BD plus alpelisib. And so the outcomes were looking for essentially any patient that got the grade 3 or the grade 4, so that's blood sugars above 14. And on the left-hand side, again, I'm going to tell you which colours are good and which colours are bad. So on the left-hand side is the Metallica trial, which is this prophylactic metformin. In the middle is the main study. On the right is a study which is a slightly smaller phase 2 study. So the grey is good. That's no hyperglycemia. The orange is not so good, but it's okay. That is grade 1 and 2 hyperglycemia, and the dark orange is grade 3 and 4. So you'll notice everything over this side of the screen is looking a lot better, especially with regards to those that get the dark orange, grade 3 and 4. So prophylactic metformin, sensible suggestion. What about the mechanism of SGLT2s, and why does it work? Well, obviously, you allow yourself to clear glucose from the urine, so it's a completely separate pathway entirely. It doesn't affect those receptors or anything of the PIK or GLUT4 receptors within the cells. A reminder, the main 2 effects is this glycosuria, so this I've just talked about. On the right-hand side, or left-hand side, SGLT2s lower your insulin levels. So because you've got less glucose about, your body thinks it's kind of a pseudo-fasted state, so you produce less insulin and a slightly bit more glucagon. So you're kind of in this state where you gradually deplete some of those glycogen stores because you're not storing excess glycogen because of the lower insulin levels. And in that, you get this, it's a little bit of ketosis, which is why patients on SGLT2s get just this moderate, small level of ketones. And this reduction in insulin is a really good thing we've just described. The whole point of this pathway is to try and get the insulin levels down. So giving an SGLT2 that will lower your insulin levels is actually a benefit. And so the concept is, as well as on the kidney, you'll get less glycogen. And it works similar to a ketogenic diet in that respect. Your insulin levels will drop. Why is that important? So I'm going to show case 3, which is an American study. So I've helpfully put the glucose levels right in the middle of the screen, the conversions for you. So type 2 diabetes, 80-year-old, pre-diabetes prior to treatment on no medication. Day 14, hyperglycemia, above 27.7. The blue is the 4 days prior to the start of empagliflozin, and the patient was on metformin and pioglitazone. Now, actually, I probably would have left it there. Blood sugars are about, on average, 11. I would be very happy with that in this context of an 80-year-old with incurable breast cancer. However, just to prove the point, they have given empagliflozin in the red, and 9 days after starting, this is the result of the empagliflozin. So the SGLT2s really do work for this process. What about low-carb diets, then? It seems slightly bonkers in a cancer setting, doesn't it, given that we have this focus on nutrition and weight loss. But there is some evidence that tumour growth can be inhibited by lower-carb diets, especially for cancers that metabolize glucose via anaerobic respiration. So we've got less glycogen and pyruvate available. The cancers are unable to replicate and grow as fast. Mice models of breast cancer also, when you did give them ketogenic diets, result in smaller tumour volumes, reduced metastases, and prolonged survival. That's not all cancers, so it's not a blanket suggestion. In fact, there's some cancers that do worse. Melanoma, for example, ketogenic diets are very bad. Clinical trials will show it. But in mice models of breast cancer, there is a benefit because of this theoretical benefit in lowering insulin levels. So a ketogenic diet will lower your insulin levels. There's also a pilot study which has shown that as long as there's no calorie deficit, then the ketosis will correspond with lower insulin levels. That's been checked and will reduce the growth of glucose-dependent cancers. So the progression is slowed. So case 4 is a patient using low carb. And actually this one is a bit more interesting because it's a patient with type 1 diabetes in their 30s, BMI is 36, on insulin pump plus CGM, and baseline is here. So the patient was really actually quite well controlled. H1C was quite nicely in target range, and time in range there you can see is 85% at baseline. Total insulin dose of about 45 units. Started Alpelisib, time in range still at 81, but you'll notice this is quite a bit above at that point, but the insulin requirement's 207 units, counterproductive to what we've just been talking about. On the right, the introduction of a very low-calorie diet. So it was in steps. They went to 100 grams, first of all, a day, and then down to 50 grams with appropriate keto monitoring. And you can see time in range back to 100%, and the insulin was down to 114 units, so a halving of the insulin in this person. So again, theoretically, a benefit in this particular cancer. So to summarize all that, and I've caught some time back, which I'm really impressed with. It's fair to say that more than half of patients will have high sugars. And therefore, as specialists in diabetes, you're going to have to get involved with this medication going forwards. It's also worth pointing out, I would say, that not all will need intervention. So use in your mind the same things you would do for an older person who's got a length of life that's expected of less than 12 months. So as long as they're going to be safe and the outcomes were not really any different depending on the glucose levels in the particular trials that we're talking about. Ensure pre-screening, especially with fasting blood glucose, because it seems to be the best marker, more than HbA1c. Identify those at higher risk, so over 75, BMIs above 30, or those with diabetes or pre-diabetes, and decide on a monitoring plan. First step is also to decide what your oncologist is going to do. They're going to treat patients with diabetes. They're treating technically by extrapolating evidence currently that there isn't any. So there really needs to be a thought process and a decision amongst probably both teams as to the way you're going to play it in your services and monitor. As treatment options go, I would say considering low-carb diets is not a silly thing to do as long as it doesn't impact on the patient's joy of life. Like I would not enjoy a low-carb diet, a ketogenic diet. I wouldn't. I know I wouldn't. I just, I get too hungry. I like a donut, it's just... So you have to, I think patient preference has to come into it, but there is a benefit in slightly reducing the carbohydrate and therefore any insulin drive in the body. Maximize use of medicines that don't increase. And actually, in the order of evidence I've seen so far, and we do need to pull a group together nationally to try and firm this up, metformin is a no-brainer. SGLT2s are very sensible in the context. I think they've probably got the best ongoing evidence in this group so far, and the theoretical benefits I can really understand. Pioglitazone, once again, as long as there's no heart failure or reason not to use the medicine, you're not going to get bladder cancer in that time frame or an osteoporotic fracture. So I think it's, for pioglitazone, it can help, via the GLUT4 pathway, it helps to sensitize the cells to the effect of insulin already. So you get away with less insulin. And if you do need to use insulin, I think I would say, where possible, try to continue to utilize the agents that will be insulin sparing as much as possible. Because you want to keep that dose low, and therefore having a slightly higher target range is probably okay. Any questions?
We have loads of questions. So I'm going to skip a few. So I'm going to skip a few of the first ones because I think you kind of answered those in your slides. But we've got one here that says, would you recommend using CGM in every patient that has this medication?
I think the thing is, I think it depends. You're not going to certainly ask GPs to do it. And that's the first thing. There's a small number of patients at the moment. For most services, you're talking maximum 20 patients a year was estimated. And I think to start with, if you're the service that has a couple of free sensors there, or you've got a little pot of them that you want to get experience, then it'll be sensible for you to get experience in the first couple of weeks, maybe by giving one of your own sensors. I wouldn't say it's sensible to be asking GPs to do it. There's also some thought process around, what's the most intensive or what's the most cost-effective way for a service? Yeah, they're not that expensive, and we're given a medicine that costs about $5,000 a year. So for the cost of 40 quid for the first 2 weeks, I don't know. I think there's lots of other tests that we do, lots of other blood tests that are much more expensive in this group of people. So I think as you're gaining experience, it would be very sensible to try and get as much experience as you can to start with. And once you've gained experience, maybe then think about how you might go forward after that.
Can insulin be used as a rescue medication for 1 to 2 days until the hyperglycaemia resolves?
Yeah, so always. However, as you've seen from most of the cases, it very rarely responds to insulin, especially...
It didn't touch my lady because we didn't know what to do. There was no guidance. The only guidance we had was the SPC thing inside the packet that said, consult the diabetes team. Yeah. And we're like, but we are the diabetes team.
Yeah. And I think it's those first couple of days of COVID when everyone was on Dex and COVID together and you go, I've just given this patient 160 units of insulin and it's not touched it.
Yeah.
So you might think you're doing something beneficial, but actually you might not be. You might actually be making things worse. So until we've got evidence, I don't think there's any... If you're not getting there, don't chase it. I think you really try to optimize the things first of all. There is some caution to be had about starting SGLT2s when the sugars are so high. And there's a reminder about that. Side effects are higher. You really need to make sure we're doing sick day rules, and ideally make sure they're counseled on keto monitoring if you're going to use that pathway.
Somebody's written, would you suggest the risk versus benefit for 6 to 18 months of life and the intense education and added interventions at end-of-life care? Is it really needed? How do patients see this?
Yeah, I think it's difficult for us to see that, isn't it? But we don't do cancer day in, day out. And I think that, progression-free survival is the kind of marker for most of these studies. And they're shown to be cost-effective by extending your life by 5 months, because the value of those months are really important to that person. So I think you have to get out of your mind, 5 months in your life is not valued the same as someone that's only got a year left to live without survival. So it comes down to the person always, and 5 months, they could do a lot in 5 months.
Yeah, my lady was only
symptoms.
My lady was only 42.
Yeah.
Somebody's asked, would this be the same for, I have no idea how to say this, ribociclib? RIBOCICLIB.
So that's one of the CD4/6, so not to the same extent. Okay. So the Alpelisib is the only one in its class currently in the UK. The others are the CD4/6 inhibitors that you use earlier in the pathway, so they don't cause the same effects. Yeah. Thankfully.
So last question, are we going to get some guidelines for this?
So I've really tried, so I'm trying to pull together a group. We're in early chats with ABCD and a couple of others, and actually Ketan from ABCD is currently speaking to his American colleagues, given that they've been using this for 2 years. So actually a lot of the guidance that I think will glean will be from the American guidelines, PARTHA.
Hello?
So can I suggest you involve one of our nurse colleagues on this one?
We're the ones that brought it to him in the first place. No, so I was like, what do we do?
But there's a wider thing I was going to say is that, I mean, first of all, this is an example of how national bodies work because NICE have never involved the diabetes team in the slightest. The second thing is that what's your view on the fact that actually there's so many immunotherapy coming? It's not just diabetes, is it? We've got thyroid problems coming, it's everywhere. So is there an option to widen the guidance to look at all the immunotherapy drugs causing the diabetes? Because without that, you have no business case in play, is what I would say. So that would be my ask, is worthwhile looking at, there's quite a fair few drugs now, and oncology, there's a number of drugs coming through. That's just the point to me.
I think, as you say, the endocrinopathies in general with a lot of these medicines, and we feel it again in MS and thyroid and other bits and pieces as well, it is difficult going forward. I feel a bit like a radiologist at times. You know, they moan that you go, we just set up this new pathway and you send them for scans and we haven't got any radiologists to do it. And they moan constantly about it, but I feel for them now because we get dragged in just to go, well, actually, I've got an extra 60 patients a year that you're now going to have to see. But you didn't know about that beforehand and we're not going to fund you for it. And they're complex. So yeah, I think that we do need to kind of work collaboratively with the oncology and chemotherapy boards to try and figure something out, definitely.
Thank you very much.